Good afternoon, and thanks for joining us for today's Healthline. I'm Courtney Butts, your host, and this is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering your questions live in the studio today. We'll be opening those phone lines soon, but as a reminder, please make sure you are in a quiet room when you call, with your TV turned all the way down so that we can hear your question. Our number is 318-219-4569. We'll have that number on the screen. And joining me today is Dr. Gazi Zibari. Good morning, or good afternoon.
Good afternoon.
Thanks for joining us.
I'm glad to be here.
Awesome. Well, you're with John C. McDonald Regional Transplant Center of Willis-Knighton, so we're going to be talking about pancreas and kidney transplants.
Absolutely.
Right? Awesome. So give me an overview of, it's National Donate Life Month, so this is really important for people to consider maybe donating, right?
Absolutely. There is significant need for organ transplantation, organ donation. Every day, some 18 to 20 people actually die while they're waiting for organ transplantation. If you could imagine looking at Tiger Stadium, there are more people needing kidney transplant than Tiger Stadium could hold.
Wow.
Not to mention about liver, about pancreas, heart, lung, intestine, and what have you. So there's significant need for them. And on top of it, if you could get a kidney transplant, for certain you'll have better quality of care. And if that kidney work at the end of the year is actually the cost would be equal to dialysis. Beyond that will be significant saving in regard of money. Just you'll be paying for immunosuppression and what have you. So if I have it my way and I have an access to an organ, by all means I would go for it. And clearly living donor kidneys are better because they function faster. You don't have to put them in ice, especially from a family member, although any living organ is better than cadaveric because you put it in ice. Nevertheless, technology nowadays we're having, most of these organ work just fine.
Right, and so with kidneys, we have two of them, or usually you're born with two of them, right? And you can, like you mentioned, be a living donor, so you can still function with just one kidney, is that correct? When
I was doing my fellowship at Hopkins in Baltimore, there was a big sign on the highway that says, God gave you two kidneys so that you could donate one. Clearly, you're right. We have patients being transplanted in early 80s. They're still living with single kidney, doing very well. So yes, indeed, you should be able to sustain with one kidney. We would never take a kidney out of potential donor if we know that other kidney would not take care of them. Now, nobody's godlike. You may get in a car wreck, you might get drive-by shooting or something like that, losing other kidney. But what federal government done, very noble policy and law to say that if somebody is a donor and lose the other kidney, to put that name on top of list for a kidney transplant. It's very, very rare to see a donor who need a kidney transplant.
Right, okay. Well, good to know. That's good. And so who is a potential candidate for, kidney or pancreas transplant?
All those people who needing dialysis, and people, for example, if they are type 1 diabetes, then potentially they could be a candidate for a combined kidney pancreas transplant. Even nowadays, type 2 diabetic patients, if they are not overweight and otherwise healthy going for a kidney transplant, they potentially could get kidney pancreas transplant. Of course, they have to be healthy, their heart pump has to be good, comorbid condition has to be well taken care of, social support is necessary, and they have to be compliant with their immunosuppression because they have to take medicine for the remainder of their life. So we have multidisciplinary team, we have cardiologists, nephrologists, hepatologists, endocrinologists, coordinator, social worker, dietitian, entire team. They evaluate these patients to make sure they are well fit, and if their testing need to be done, we'll refer them to get proper testing done. Somebody who's a smoker, we got to check the lungs. Somebody who's having coronary artery disease, we have to have cardiology to see them until they're fully evaluated, and when we see that they'll be good candidate, we'll get them listed and United Network for Organ Sharing, a single listing nationwide. Although organ donors from this vicinity within 250-mile radius have preferentially will come to patient in this area, and people could actually make direct donation to a center of their choice. For example, if a family have a deceased donor, they could make direct donation to our center, or they could donate it to anyone anywhere nationwide.
Very cool.
Yeah.
So let's say that I was wanting a pancreas or kidney transplant. What is the average wait time for something like this?
You know, it's an important question. When I came back to Shreveport in '93 after my fellowship, I would say that most of our people would not wait more than a year for kidney transplant. Unfortunately now, 5 to 7 years has become a norm.
Wow.
For kidney transplant. Now, pancreas transplant, if you get pancreas kidney, you could get those organs a little faster because there are more pancreases could be used, and whenever you get pancreas, kidney could come with it. But kidney is a significant problem because of lack of organs. That's right.
Gotcha. That's a long time, 5 to 7 years, and you mentioned that some people may end up passing away while on this wait list. Is that correct?
Absolutely, and that's the sad thing about it. We know there are many people dying and taking those organs with them to heaven when heaven knows we need them here. So I think it's very important to consider to save others' life. We have family member that would come to see the recipient of lung transplant, recipient of heart transplant, of kidney, liver, pancreas, and they are very proud to know that part of their loved one continue to live because of giving gift of life. So you may not appreciate it until you have a loved one needing organ transplant, and suddenly you say, why people not donating? And getting public educated, I think, is very critical.
Right. And so can anyone donate, or is there any kind of guidelines if you are considering being an organ donor?
Anyone could be an organ donor. You could actually donate to the list, or you could give it to a friend. And again, we have to make sure that the person who come forward, they mean it from the bottom of their heart. There's no pressure on them. They're not trying to get some benefit out of it and what have you. As long as there's no issues, psychological issues, by all means, you can be an organ donor.
Gotcha. Yeah. And so you said one of the most common is maybe for these transplants is if they're on dialysis, right?
Well, absolutely. But you have to be approaching dialysis or already on dialysis in order to be qualified to undergo kidney transplant. If you look at the total of people nationwide who are actually on dialysis or being transplanted, some over 500,000 people. In fact, over 600,000 people are either on dialysis or being transplanted. And unfortunately, or maybe fortunately, because we have done so well that people live long enough down the road, 30 years down, 20 years down, might reject that first kidney, might need another kidney. And so we have been like enemy of our own because our patient done so well, and we are very lucky to see that progress happen because of multidisciplinary approach, good infectious disease department, and see critical care, nursing care, and what have you. So these people have tendency to live much, much longer, and because of that, the listing of patients escalate. And the number of organ donors have really not increased much. Nowadays, we even doing donation after cardiac death, not brain death, but donation after cardiac death. For example, if I'm in vegetative state, but still I'm breathing over the vein, therefore, what they could do, families say, well, we want to donate the organ. They'll take me to operating room, two physicians would actually remove the tube out and wait until EKG became flat.
Gotcha.
And then we'll proceed, after 5 minutes, we'll proceed to recover those organs.
Very cool.
That's right, yeah.
Well, we have someone on the line. Wayne, what is your question for the doctor today?
Yeah, I was wondering if they did lung transplants, and I've just recently been diagnosed with pulmonary fibrosis, which is a terminal illness, and I want to know what what the wait time would be on something like that, or if they even can do something like that.
It's a good question, and unfortunately, often we see patients with that kind of problem. And yes, depending on your comorbid condition, your heart pump, and what have you, and yes, you'll be qualified for lung transplant. And there are institutions doing lung transplant, all over the country. Of course, we're not doing them here in Shreveport, but we have people, we have sent them out, and they have successfully transplanted and came back enjoying life just the way we do liver transplant and kidney transplant.
Right. So are you familiar with pulmonary fibrosis at all?
Yes, of course. We deal with it. We have.
Can I ask you a question?
Sure.
They said I have IPF, that means the cause is unknown, but I have evidence of a year ago in March, my lungs needed no kind of acute care, or there was no emergency, no life-threatening problems. I lived in this place where the place was supposedly been recently fully renovated, and all they did in actuality was mask over a problem. After living there for 9 months, the place was actually mold infested, and after 3 months there, I had a first upper respiratory infection, and then I went back, and then in December, or actually in the end of October, and we moved out of there. But then all of a sudden in December and January, I started having this shortness of breath issue, and then I finally got in to see a pulmonologist, and they said that I had IPF. And to me, why would it be IPF if mold can actually cause that problem? I don't understand.
Well, I think that you are in great hands. And the first thing we do when we have somebody with pulmonary problem, you have to have a pulmonologist on board who's specialized in this area, and clearly he has panel of testing he would do, and if he cannot pinpoint it, then it'll be basically idiopathic, unknown etiology, unknown cause. And you are raising a good question, say that you think this may be due to fungal infection and what have you. Usually, if they would have felt this is related to fungal, they would not call it idiopathic, but I suspect they say there's something more than that. A small example of it, we have had a patient who had COVID infections with bad pulmonary infections, been in ventilator for 6-7 months, and ended up actually doing lung transplant. So my gut feeling would be the best for you to stay in touch with your pulmonologist, and yes, indeed, you could be qualified to get a lung transplant, provided your heart pump and other organs are okay.
See, I'm supposed to go tomorrow to have one of them pulmonary function tests done, and that will only be the second time I've seen her. I saw her the first time, and she suspected, that I had that IPF. But I mean, I got obvious. The place, I did a mold test in the place. It was like 7 different molds living in that house. Yeah. And as they lived there, they had painted over it. The house had an oversized air conditioning system in it, and if you oversize the air conditioner, it creates a cold, wet dampness, and what happens is the unit will run and cycle off before it can actually condition the airspace. So the place was constantly sweating inside the walls as well as on the outside, especially in the summertime, which is a lack of insulation.
You got to be removed from that environment. My word of advice, that's what you need to do.
I have moved from there, but I'm pretty sure it's probably too late.
Yeah.
I think the damage is done.
Sure, absolutely. Wish you best of luck.
Thank you, Wayne, for your question. Well, if you're just joining us, please give us a call at 318-219-4569 to talk directly with our doctor. So I have out of curiosity, let's say that, I'm visiting with my primary care physician. Is the doctor the one that is maybe deciding or referring to someone like you for these transplants?
In large part, most of patients who come to see us, they are actually already been sent to nephrologists, and nephrologists done everything possible they can to maximize kidney, delay hemodialysis. And when they get ready for dialysis, for one, they send them to us to establish IV fistula or graft in the arm, and then they would ask us to evaluate the person for possible kidney transplant, and the initiation would start with nephrologist referral, and then we'll do whatever necessary to make sure they'll be candidate and no major complication or risk of them developing major complication. For example, you're diabetic and insulin, we know that those patients are prone to develop vessel problem and coronary artery disease. We'll evaluate them to make sure that there is no such issues, and if it is, we'll intervene to maximize them before we list them.
Right. So are there ways to increase, let's say, let's say I'm on the list, is there a way to increase my chances of getting that transplant?
It's only way for you to increase your chances if you have rare antibodies or too many antibody in circulation, that you have gotten a bunch of blood and blood product at younger age, and now your antibody in circulation is so high, then the federal government would give you a chance, put your name higher up, because likely than not you would be positive cross-match, you would not be candidate for that kidney. The area where they could benefit from that is actually with liver cirrhosis. When they have cancer in the liver, it cannot be resected. And after a period of time, they'll give them extra points while we downgrading the cancer, trying to embolize it, killing it, giving chemotherapy or ablating them. At meantime, they would give them extra points so that they could potentially be considered to give them a little more point to get top MELT score and to be transplanted. Otherwise, for the kidney, if you run out of vascular access site, for example, you have to ask for exemption, because no longer you'll be dialyzed and risk of dying is real. So there are limited situations, but yes, those potential could get a kidney, ideally to have a family member or a friend or somebody to come forward to give you a kidney.
Right, yeah. And again, reiterating the importance of donating life.
That's right.
Well, so you mentioned cancer, so maybe we can switch gears here. Tell me a little bit about pancreatic cancer. From my understanding, you're pretty asymptomatic maybe for a little while before you know? Or is that?
Pancreatic cancer is fairly aggressive. There are different types of pancreatic cancer. Adenocarcinoma is the worst one. Of course, we're having duodenal cancer, we have ampullary cancer, we're having neuroendocrine tumor cancer, we're having cystic neoplasm of pancreas. In large part, those lesions in the tail and body of pancreas could get very big and very large, and it could metastasize before even patient know about it. Generally speaking, those lesions are easier to resect because all you have to do cut it out. You do not have to worry about reconstruction. On the other hand, the lesion in the head of pancreas, patient might detect it earlier because they came in yellow jaundice. They end up losing weight because of pancreatic enzyme not getting in the GI system and what have you. They have tendency to be detected a little earlier. The problem, those cases, surgery are very complex, but we call it Whipple procedure. And Whipple procedure, you have to take head of pancreas out with the duodenum, part of the stomach, gallbladder, bile duct, and then you have to reconnect the intestine to the pancreas, to bile duct, to the stomach, in order to reroute it and get it taking care of it. I think from the technical part, we have done significant progress. Unfortunately, morbidity is still very high. We really have not made any major headways on regard of morbidity is still around 35 to 40%. However, mortality dropped from 18% to 3 to 5%, which we done good. Nevertheless, it's very aggressive tumor. Often we believe that these patients should get upfront chemotherapy, because we believe that biology of cancer would determine whether or not patient going to live or not. Those patients who respond very well to chemotherapy, likely than not, if you resect with clear margin, longevity would be much, much better than those if you just jump in and resecting it without giving upfront chemotherapy.
Gotcha. So the Whipple procedure sounds pretty intense. Is that recommended for most patients with pancreatic cancer?
This is what is required if patient has tumor in head of pancreas. We used to make a very big incision subcostal from one side to the other one. And then we ended up doing laparoscopy. Now we actually doing those procedure with robot. We can resect it and hook it back up with robot. So there are different technique of doing them, open, laparoscopic, or robotic. It's dealer's choice. Whichever technique is best and easiest, safest in your hand, that's what you should do for your patient.
Gotcha. And for someone that has been diagnosed with pancreatic cancer, can they receive a pancreas transplant for their pancreas?
Generally speaking, no. And in large part because pancreatic cancer is very aggressive. And if you give a pancreas transplant to the patient, you have to give immunosuppression. And if you give immunosuppression, you'll make immune system weak. If there's any cancer cell in circulation or anywhere hidden in body, could actually reactivate and take over. And that's why we do not recommend for that. Now, if you have neuroendocrine tumor of pancreas, metastatic to the liver, or even nowadays with colon cancer metastatic to the liver, if primary site is controlled, and you're given chemotherapy and these lesions are shrunken and nothing else popping up nowhere in the body, actually they could be considered for liver transplantation, especially with colorectal. Is brand new. We have very limited experience with it, and there are center clinical trials focusing on it, and some of the outcome is actually pretty impressive, especially with younger one who actually liver been taken up by cancer, and there's nothing you could do about resection. But yet, they go a whole year and a half. These are not increasing, not going nowhere else. I think those patients should be considered for liver transplantation. Yeah.
Gotcha. So with pancreas and kidney cancer, we haven't really talked about that. Doesn't sound like something that's very common.
It is not very common, but clearly it does happen. In fact, sometimes these patients, when they are on dialysis for so long, we have transplanted, then they sometimes get cancer in the native kidney.
Wow.
And again, we have people who are focused only doing that, like some urologists. I take kidney out robotically for kidney transplant, and I do take out kidney out with robot for malignancy as well. So we do see a good number of those cases. The most complex renal cell cancer is when the tumor thrombus extend in the main vein going up toward the heart. If that gets filled up, they are very risky. You really have to get the CV surgeon involved. The surgeon who's taking care of kidney, and sometimes multidisciplinary approach to get that taken care of it, to get clear margin and minimize risk of thrombus breakup and going to the lung and kill the patient. But most of them you could detect it early. These potentially could be ablated percutaneously with heating probe, or you could do local resection, or you do total nephrectomy depending on location and size of tumor. But they are not as bad as pancreatic cancer.
Right, okay. And so with pancreatic cancer, the gold standard for this is really the chemotherapy.
The gold standard resection with clear margin, provided you could give that safely. The whole idea of chemotherapy is to give it to see if it's aggressive cancer, even despite the chemotherapy will spread. So resection would not done patient no good. That's why we believe that upfront chemotherapy in pancreatic cancer is good, because one, hopefully it'll shrink it. Secondly, if there are some cell in circulation, hopefully it'll kill it. And lastly, if you operate and a complication happen, you may not be able to give chemotherapy immediately after surgery. That's why we like to give some upfront chemotherapy, reassess, reevaluate. And nowadays there are biomarkers. We know, and I believe that before too long we could pinpoint whichever cancer is most aggressive, where maybe should not be resected because of getting the genetic testing and these biomarkers to look at it and kind of taking it from there.
Right. Yeah. And prevention is key. Which do you think that the genetic testing will help people find it early if they have a mutation?
Absolutely. If they have genetic testing and they have that certain genes, they can be monitored very closely, very carefully, regularly. Any lesion popping up, it can be detected, can be removed. I know a patient with breast cancer who incidence is so high in their family. I've seen them, they go for bilateral mastectomy. So I do not want to be dealing with malignancy down the road. So I think this genetic testing will help our patients, no doubt about it, and hopefully be able to detect malignancy before it gets too big and spread, and you should be able to cure it.
Is there any screening options? I know there's screening for breast cancer and for colon cancer, but is there any screening options available for pancreatic or even kidney cancer at this time?
We really don't have any major marker at this time. There are some tumor markers nowadays we checked and what have you. Nobody really adopted it in larger scale. Because it's not very, very sensitive, and what we have seen though, because people doing this imaging modality for other testing, they do MRI of the spine, they do CT for the lung, they do something for pelvis, and they actually see a lesion in the pancreas or in the kidney or in the liver. So what we call it incidental adenoma, a lesion detected while they're looking for something else. And again, because of that, we are able to resect more pancreatic cancer than ever before. When I was doing my chief residency here, if you would have done a dozen of Whipple a year, we felt we did great. And reason was that most of the patients came to us, it was already spread and metastasized before we even saw the patient.
Oh,
so
wow.
We are seeing them a little earlier. And our oncology is doing much better job actually to detect and take care of it.
Gotcha.
In regard of chemotherapy, shrinking it, yeah.
Awesome. Well, let's go back to talking about transplants. We only have a couple more minutes
Sure.
left. But tell me about you mentioned interdisciplinary team approach with something like obviously cancer and then also the transplant. So tell me how it all works together.
For example, every Monday we have a multidisciplinary team. We go over all patients who have problems and complications. And then we have selection committee for kidney, for pancreas, for liver. There are transplant hepatologists, nephrologists, the coordinators, social workers, dietitians, surgeons. A spectrum of people sitting in those committee and being worked up, and we'll go through them whether or not this patient will be qualified or not, and why is or is not. We do that today at 4:30 at our cancer center. We'll be discussing when patients having malignancy, been liver cancer, pancreas cancer, biliary cancer. We have oncologists, we have interventionists, we have radiology, we have GI doctor, we have pathologists, we have surgeons, all sitting in the same room to discuss these cases, and then we'll come up with plan of action. Of course, it's up to the patient to decide whether or not they want to have it or not, but it's time, I think, we very well spent. Otherwise, I have to call 4 or 5 people to see this what need to be done. They will decide this is the best solution for this patient, and this has really enhanced quality of patient care in my mind, even though it take our time out of busy schedule, but
right.
Like I said, it's time well spent for sake of our patients.
Absolutely, and they feel supported, and they're not walking through this very difficult and life-changing decision alone.
That's right, absolutely right. It's nothing like having these patients at home and not talk to anybody, don't know what to expect and to anticipate. So we always get them in, hoping to reassure them and kind of initiate their workup.
Awesome. And one more time, where are you located at?
I'm at John C. McDonald Regional Transplant Center at Willis-Knighton Health System here in Shreveport, Willis-Knighton North.
Very awesome. Well, I learned a lot about the pancreas, about the kidney, especially transplants. I know that it's really important. If you are interested in becoming an organ donor, then definitely consider it. It's National Donate Life Month.
Absolutely. Nothing is noble as giving gift of life. Clearly, saving life is extremely noble in my own mind.
Awesome. Well, thank you so much, Dr. Gazi and Zibari, it's been a great time talking with you.
Thank you for the invitation.
Absolutely.
My pleasure.
We hope you have a happy and healthy day.